Hello and welcome. On behalf of the Kentucky Medical Association, we are pleased to provide this continuing medical education activity to physicians across the state of Kentucky. This session is approved to meet the Kentucky Board of Medical Licensure's mandated requirement for domestic violence training for physicians. This session has been pre-recorded for your convenience. In order to claim CME credit, participants must complete the post-activity evaluation through SurveyMonkey. A link will be sent electronically to participants following confirmation of their engagement with the activity through attendance tracking. Question and answers will be obtained through a post-activity session with the presenter immediately following the release and showing of this presentation. That question and answer session will also be recorded and be available to participants in an enduring material format. For CME purposes, all planners and presenters disclose no relevant financial relationships. The Kentucky Medical Association is accredited by the ACCME to provide continuing medical education to physicians. The Kentucky Medical Association designates this internet enduring material for a maximum of 3 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. CME certificates will be mailed to attendees upon receipt of post-activity evaluation, and if you need additional assistance, please contact KMA staff with the information provided on this slide. I will now turn it over to our presenter, Meg Savage, Legal Counsel for the Kentucky Coalition Against Domestic Violence.
Welcome. I'm here today to talk to you about intimate partner violence in the healthcare setting. As Miranda said, my name is Meg Savage. I'm legal counsel for the Kentucky Coalition Against Domestic Violence. At the end of this session, we will talk a little bit more about my organization and the services that are available to survivors of intimate partner violence in the Commonwealth of Kentucky. So you may be asking yourself as a physician, why am I here? What do I as a physician need to know about intimate partner violence, about any legal obligations that I have as a physician, and how can I help survivors to find the services that they need to become safe? First of all, under KRS 194A.540, there is a requirement that all physicians who practice primary care or are psychiatrists to have 3 hours of training within 3 years of licensure on domestic violence, covering the dynamics, effects on victims, legal remedies, lethality and risk, model protocols, community resources, and reporting requirements. So that's what we're going to be talking about in the next 3 hours. There are some considerations, though, beyond simply the legal requirement that you have this training. Intimate partner violence is a public health crisis. That cannot be disputed. The statistics that we have show that in Kentucky, 37% of women and 31% of men experience intimate partner violence. Nationally, that statistic is 1 in 4 women and 1 in 7 men who have experienced severe physical violence from an intimate partner. However, only 1 in 3 people who are injured by an intimate partner receive medical care for their injuries. Understanding intimate partner violence, how to screen for it, and how to respond appropriately to disclosures of IPV will improve the health of your patients. You can make a difference in a survivor's life. And even beyond the physical injuries that you might be called upon to treat, it's important to think about intimate partner violence and trauma-informed care. Experiencing abuse can affect how we feel, think, and respond to other people and the world around us. It can also increase risk for developing mental health and substance use conditions. Experiencing multiple forms of abuse and oppression over the course of our lives can further increase these risks. At the same time, stigma associated with substance use and mental illness allows abusers to use these issues to increase control over their partners, undermine them, and discredit them. The symptoms that we like to think about are actually survival strategies. They're adaptations to intolerable situations that are made when real protection is unavailable and normal coping mechanisms are overwhelmed. This understanding of IPV underscores the importance of ensuring that responses to survivors of IPV are trauma-informed, and that includes responses from the medical community. In part one of this presentation, we're going to help you understand more about intimate partner violence. We're going to go over some definitions, talk about the dynamics, the causes and effects, and what are the barriers to escaping a battering partner. At the end of part one, you should be able to define intimate partner violence, describe the power and control wheel as it relates to intimate partner violence, and list at least 3 barriers to escape that survivors of IPV face when trying to leave an abusive partner. First of all, we do have a legal definition of domestic violence and abuse and dating violence and abuse in Kentucky. These definitions are found in the series of statutes that cover who can get a protective order in Kentucky. KRS 403.720 defines domestic violence and abuse as physical injury, serious physical injury, stalking, sexual abuse, strangulation, or assault, or the infliction of fear of imminent physical injury, serious physical injury, sexual abuse, strangulation, or assault. In order for it to be considered domestic violence and abuse, this type of action has to occur between family members or members of an unmarried couple. Under Kentucky law, in our protective order statutes, a family member is defined as a spouse, a former spouse, a grandparent, a grandchild, a parent, child, or stepchild, or any child where the child is being abused by someone living in the same household. These individuals would be eligible to apply for a protective order under Kentucky law. Also included are members of an unmarried couple. These are people having a child in common, or who live together, or have lived together as intimate partners. The definition of domestic violence under Kentucky law goes beyond intimate partner violence. As you can see, it includes grandparents and grandchildren, parents and children, and stepchildren. Today, we're going to be focusing mostly on intimate partner violence, but it's helpful to know that these individuals also are eligible to file for a protective order. We also have a statutory definition for dating violence and abuse. This is found in KRS 456.010. This is the beginning of a series of statutes that allows individuals who are experiencing other types of intimate violence to apply for a protective order as well. Under this statute, dating violence and abuse is defined very similarly to domestic violence and abuse. So this language should look familiar. Dating violence and abuse means physical injury, serious physical injury, stalking, sexual assault, strangulation, or the infliction of fear of imminent physical injury, serious physical injury, sexual abuse, strangulation, or assault between persons who are or have been in a dating relationship. So that's the difference between dating violence and abuse and domestic violence and abuse, is the relationship between the two individuals. Under Kentucky law, dating relationship does have a definition, but it's very brief. It's basically a relationship of a romantic or intimate nature. There are some guiding principles under our law so that courts who are considering a protective order case can determine with more specificity whether the two individuals in front of them are or actually have been in a dating relationship. But for the purposes of this training as a physician, I think this is a sufficient definition for you to keep in mind. I'd like to point out the second bullet on this slide, that under our Kentucky laws, it's not required that there be an injury or that there be physical contact in order for it to qualify as domestic or dating violence and abuse. The infliction of fear of something imminently happening that would cause harm to the victim is sufficient in order for them to go and seek a protective order. This is important to note as well. Some people are under the misconception that if there was no injury, they can't get a protective order. That simply isn't true. So now you know as a physician that if somebody is expressing to you that their partner has done something that inflicted them with fear that they were imminently going to be hurt in some way, that would be enough for them to at least apply for a protective order. We're going to talk more about these specific crimes in part 3 of this presentation. These are part of the legal definition of domestic and dating violence and abuse. Physical injury, serious physical injury, sexual abuse, sexual assault, stalking, and strangulation. I'd like to point out that even the infliction of fear that one of these is imminently about to happen is a crime under Kentucky law. It's called menacing, and it's a Class B misdemeanor. So actually, in order to get a protective order in Kentucky, the petitioner does have to show that a crime has been committed. Now, you may be asking yourself, well, that's all fine and good. Now I know the legal definition of domestic violence and abuse and dating violence and abuse in Kentucky, but why do I need to know this? Well, these definitions dictate your statutory obligation as a physician to respond to patients who are victims of domestic and dating violence and abuse. So you need to understand these definitions in order for you to know what it is you need to do when you are being given information by a patient about some violence that's occurring in their life. More information about that duty will be provided in part 2 of this training. I'd like to talk a little bit more about definitions and intimate partner violence and talk about what really is happening when one person is battering their partner. Intimate partner violence is actually a pattern of behaviors. It's used by one person to gain and maintain power and control over another person in an intimate relationship. It's as much about coercive control, and possibly more so, than it is simply about physical violence. What do we mean when we talk about coercive control? That's been defined as utilizing a combination of abusive tactics such as isolation, degradation, surveillance, manipulation, gaslighting, stalking, threats, physical violence, and sexual coercion, which may vary over time, setting, the specific goals of the abuser, and the reactions of the survivor, who's also called a victim. In your case, it may be your patient. But these tactics are used to establish dominance over the partner. Physical violence may or may not be one tactic used, either consistently and frequently, or sporadically, or even in isolation. So, what do we know about why some individuals choose to exert coercive control over their partner? Abusive behaviors and violence are learned behaviors. They are learned through observation, experience, and reinforcement. It's a sad truth that children who grow up witnessing domestic violence often, if they're male, become abusers themselves as adults. They've learned this behavior through observation and through experience. Their behaviors are reinforced through a variety of cultural, community, and systems, factors that make it acceptable for individuals to utilize these types of behaviors. Intimate partner violence is not caused by genetics, mental illness, alcohol and drugs, anger and stress, or the behavior of the victim, or problems in the relationship. It's true that some of these may exacerbate the situation, but the bottom line is that the individual who is battering their partner is making a choice to do that. It's a behavior that they are choosing to engage in, and the purpose of that behavior is to exert power and control over their partner. So there are many life and personal circumstances which may contribute to or exacerbate intimate partner violence. But again, it's a choice, the choice to hold all the power in a relationship and to use violence and other means to control their partner and their family, often including their children. Many of the actions of the abuser may be crimes, but others may not be under our laws. Many of our societal institutions, which were built using oppressive frameworks, actually continue to reinforce IPV by making it very difficult for survivors to successfully and safely leave an abusive partner. Some of you may have seen this before. It's called the power and control wheel, and it's something that's been around now for several decades. It was developed after having a lot of input from survivors who talked about what was actually going on in their relationship at the time that violence was occurring. And when I say violence, I don't always mean physical violence. So what are the tactics that an abuser might use in order to exert coercive control over their partner? Starting at the top, we'll talk about intimidation. This power and control wheel uses the pronoun her or she to reflect that it still is a truth that intimate partner violence is a gendered crime. And we'll talk about that a little bit more in a moment. So use of intimidation, making her afraid by using looks, actions, or gestures, smashing things, destroying her property, abusing pets, which is a big one, displaying weapons. The abuser is probably going to use a lot of emotional abuse in this relationship, putting their partner down, making them feel bad about themselves, calling them names, making them think that they're crazy, playing mind games, humiliating them, making them feel guilty. Isolation is also almost always present in a relationship where there's intimate partner violence. Controlling what your partner does, who they see, who they talk to, what they read, where they go, limiting their outside involvement, and using jealousy to justify those actions. The abuser is surely going to be minimizing, denying, and blaming. They make light of the abuse. They don't take the concerns seriously of their partner. They say the abuse didn't happen. They shift responsibility for the abusive behavior and saying that the partner caused it. Using children is huge in relationships where children are shared between partners. So making the victim feel guilty about the children, using the children to relay messages, using visitation to harass the partner, threatening to take the children away. Using male privilege, and again, we'll talk a little bit more about how intimate partner violence is actually a gendered crime. But treating the partner like a servant, making all the big decisions, acting like the master of the castle, being the one to define men's and women's roles in a relationship. Using economic abuse, preventing the partner from getting or keeping a job, making them ask for money, giving them an allowance, taking their money, not letting them know about or have access to the family income. And finally, using coercion and threats, making and or carrying out threats to do something to hurt them, threatening to leave, to commit suicide, to report her to welfare or child protective services, making her drop criminal charges or protective orders, making the partner do illegal things. So these are just some of the tactics that an abuser is going to be using in order to keep control over their partner. And as has been said, we have many societal systems and institutions that reinforce this type of behavior and allow it to continue. Our educational system, the courts, the police, the media, social services, other government agencies, workplaces, economics, religion, and yes, even medicine can actually support what the abuser is doing to the survivor. For instance, if the police are called to a home and there's been a domestic violence incident, and the police respond by telling the two individuals, if I have to come back out here again tonight, both of you are going to go to jail. What type of message does that send to the survivor? That they can't reach out for protection. The way media portrays cases. I think we're all probably sick of hearing about Johnny Depp and his libel action against the newspaper in London in regards to his former wife and her allegations of abuse. And sometimes the media portrays things in a way that are very slanted, or they don't even pick up on the fact that when one spouse kills another spouse, that's domestic violence. Social services reaction. So if an individual reveals or discloses that they're experiencing violence at the hands of a partner and there's children in the home, and then the response of Child Protective Services is, we'll take your children away because you're being abused by your partner. Again, it makes survivors very leery to reach out for any form of protection or help. So what about the medical profession? How could the medical profession possibly be doing things that would support the continuation of abuse in a relationship? One of the most important things that we're going to talk about today is how physicians have the ability to screen for intimate partner violence. And if that is done in a thoughtful, meaningful way, then that can really help a survivor find a way out of an abusive relationship. So simply not asking the questions or asking them in a rote manner, not knowing how to handle a disclosure, ignoring the possibility that violence might exist in a relationship, that might just be one example of how the medical field isn't doing its part to try to address this public health crisis. And then even outside of our institutions, we have things such as our values, our culture, our language, our traditions. And these all can tend to support an idea of misogyny, ideas that violence is acceptable, or even to be applauded, that we should worship individuals that are exceptionally violent or use violence to solve problems. And seeing what's portrayed in our media is definitely influenced by our culture. So these are all layers of control and oppression that make it very difficult for a survivor of intimate partner violence to escape from that abusive partner. So, as a physician, what should you look like when it comes to survivors? What does a survivor of IPV look like? Well, actually, it could be someone from any race, ethnicity, religion, education, or socioeconomic group. The person might be married, divorced, single, widowed. They could be heterosexual, homosexual, bisexual, pansexual. They could be cisgender, male or female, transgender, male or female, or non-binary. They could be young or old. They may or may not have children. They may be economically dependent, or they might have a good job and income. They may or may not have seen violence in their home as a child. They could be of any size or strength. They might be documented or undocumented. They could be forced into prostitution or sex work. They may or may not have a mental or physical disability. They could be from a rural area, a town, or a big city. They might be passive or aggressive or assertive. They may be English speaking or have limited English proficiency. They might have great self-esteem or low self-esteem. They may use alcohol or drugs, or they might be sober. They may be isolated, or they may have an active community life. Basically, there is no typical character profile or set of personality traits or life circumstances that define a survivor of IPV. However, the best determinant of being a victim of abuse is gender. These statistics that I'm going to go over came from the National Intimate Partner and Sexual Violence Survey of 2010. 1 in 4 women and 1 in 7 men experience severe intimate partner physical violence. 1 in 3 women and 1 in 4 men have experienced some form of physical violence by an intimate partner. You may be thinking, well, those are fairly close statistics. I don't see much of a difference. But we're talking about some form of physical violence. 1 in 7 women and 1 in 25 men have been injured by an intimate partner. Here's where we start seeing a big difference in the level, the severity of the violence that's going on in this relationship. So physical violence might be something like a shove, a slap, a push, but now we're talking about people who have been injured to the extent where they're going to need medical care. 1 in 10 women have been raped by an intimate partner. Approximately 1 in 71 men in the United States report being raped. That may be an underreporting because men are reluctant to report sexual assault. 29% of male rape victims were raped by an intimate partner, which is predominantly a male partner. 1 in 7 women and 1 in 18 men have been stalked by an intimate partner to the point which they felt very fearful of harm. Male victims reported about half of their stalkers were male. So as you can see through these statistics, women are still at greater risk of experiencing physical violence, severe physical violence, rape, and stalking. And typically, many of the males who report this type of intimate partner violence, their partner is male. So we feel comfortable at the Kentucky Coalition Against Domestic Violence stating that IPV is still a gendered form of violence. 1 in 13 male murder victims are killed by intimate partners, but 1 in 2 female murder victims are killed by intimate partners. 65% of all murder-suicides involve an intimate partner. And of those cases, 96% of those murdered are female. So it's true, men can be victims of intimate partner violence. But the huge majority of those who experience IPV are female, or those who identify as female, such as trans women. There is apparently from many research studies, the rates of intimate partner violence in same-sex relationships is about equal to that of what's occurring in heterosexual relationships. But still by far, the most prevalent sign that somebody may become a victim of intimate partner violence is their gender. So we've talked about survivors, and we've gone over the fact that there isn't really any one demographic that would alert you as a physician to, oh, this person is probably more likely to be a survivor of intimate partner violence. The only one demographic that would point in that direction is their gender. So let's talk about characteristics of abusers. And again, abusers may demonstrate some or none of the following traits: excessive jealousy and possessiveness and controlling behavior, emotional dependency on the victim, poor impulse control, an explosive temper, limited tolerance for frustration, the desire to control the partner's thoughts, feelings, and actions, a history of family violence. They blame the victim for causing the abuser to abuse them. They degrade the victim, especially in front of children. They may objectify women, seeing them as property or sex objects. They may have rigid beliefs about gender roles. They may be forceful about sex and disregard the victim's wishes regarding sex, birth control, and pregnancy. They may sabotage or obstruct the victim's ability to work or attend school. And they may exhibit cruelty to animals, especially in front of the partner and children. And this is used as a means to terrorize and control their partner and their children. They may demonstrate little remorse or guilt for their actions. And often they blame the victim for everything that happens. Abusers often portray themselves as the victim in the relationship. And they often resort to gaslighting, which is a form of psychological manipulation, creating a situation that's confusing for the survivor and making them question their own judgment and their own reading of reality. Abusers are almost always very manipulative, unpredictable in their moods or actions. They may blame their abuse, the abuse that they commit, on alcohol or drug use or situational stress. They may minimize and or deny their violent behavior by blaming outside forces or influences. And they may have a Dr. Jekyll, Mr. Hyde personality. So they may be charming and friendly to those outside the family, but within the family, they definitely are exhibiting different personality traits. Just like survivors, abusers can come from every walk of life. There's no profile of age, income, education, race, ability, culture, country of origin, or religion for a typical abuser. It serves no purpose then to look for or red flag certain demographics when a healthcare professional suspects a patient may be experiencing IPV, with the exception of gender. The best tool for unearthing IPV, which may be affecting the health of your patient, is a thoughtful, meaningful, universal screening for IPV and making good referrals to services. And we'll be talking about that in part 2 of the training. Now, before we end section 1, I'd like to talk a little bit about what seems to be the #1 question that people have about intimate partner violence. Again, in a gendered way, they'll say, "Why does she stay?" Or alternatively, "Why doesn't she just leave?" First off, it should be pointed out, and it's not really unreasonable to understand this or hard to believe, that leaving a violent partner is the most dangerous time of the relationship. Knowing that IPV is centered on an abuser using a range of tactics to hold power and keep control over their partner, ask yourself, what is their likely reaction when that partner decides to leave? The answer is they will typically use any and all means at their disposal to regain control of their escaping partner. Often this means an escalation of what apparently is no longer working, and usually this means an escalation of physical violence. Abusers don't just walk away. During a separation, the risk for the fleeing partner skyrockets. The rate of attacks on women separated from their husbands was 3 times higher than that of a woman who is successfully divorced from her husband, and 25 times higher than that of married women. 75% of domestic violence-related homicides occur upon separation. And there's a 75% increase of violence upon separation for at least 2 years. So it's not a risk that goes away quickly. Over 75% of spouse-on-spouse assaults occur at the point of separation, and the majority of homicide-suicides occur at separation. So again, it's not as simple as simply leaving. It's about escaping. What are some of these barriers to escaping? What are some of the answers to the question, why doesn't she just leave? The number one reason, borne out by research, and my own personal experience after having been an attorney for 30 plus years, is the survivor's concern for their children, if there are children in the relationship. Abusers frequently weaponize the children as a means to maintain control over the other parent. When contemplating how to safely leave the relationship, survivors must carefully consider the needs of their children. Will this destabilize them? Will they have to change schools? Will they be okay if they have to live in a shelter? How will they secure new, safe, affordable housing? Often there's fear of the abusers using violence and retaliation for leaving. Will the children be safe during time sharing with the abuser? In Kentucky, it's very rare to have anything other than joint custody and equal time sharing. Abusers are more likely than non-abusive parents to seek sole custody and have a surprisingly high success rate of achieving it. The fleeing parent may fear losing custody to the state if DCBS takes the children once the violence in the home surfaces. And trust me, as an attorney that's practiced in this area of law for 30 plus years, all of these fears are very well founded. Simply leaving the abuser does not mean in any way, shape, or form that the children will be safe. What are some of the other barriers that survivors have to face? Often, the abuser has made threats of violence. The abuser may threaten to commit suicide, or they may have made threats to kill the survivor and or the children if they attempt to leave. They may threaten to hurt or kill pets. And often they do this after already having done so in front of family members. They may threaten to call ICE, immigration enforcement, or get the survivor deported, or to have them arrested or detained, or take their children away from them if the survivor is undocumented. And this is especially true if the survivor has limited English proficiency or non-English speaking and doesn't understand what their avenues of recourse are, being a survivor of violence. The abuser may threaten to take the children and disappear. They may threaten to out partners who are in the LGBT community who have not come out to family, friends, or employers. They may threaten to get the survivor fired, to harm the family and friends of the survivor. And many times the abuser has already done or attempted to carry out such threats during the course of the relationship. So the survivor has legitimate reason to fear that these threats will be carried out if they try to leave. Some of the other barriers that survivors face when thinking about escaping from this abusive partner, a big one is isolation. Often the abuser has successfully cut the survivor off from family, friends, and support networks, as well as having limited means to access community support. The survivor may not have access to a phone, the internet, or transportation to plan for their escape, line up a job, or find support services. Language, for those who are non-English speaking, is also something abusers can use to isolate their partners, and it can be a huge barrier to escaping the abuse. Financial dependency. The abuser may control the finances or be the sole source of finances for the family. It's a tactic to make the survivor dependent and further isolate them. The survivor may have no access to any source of funds to make their escape. The abuser may have run up debt on the survivor's bank cards or ruined their credit, making it so much harder to find a new home to rent or even to get a job in some cases. And systemic discrimination, racism, homophobia, transphobia, and ableism make it dangerous for many survivors to turn to law enforcement, social services, or the courts for protection when they leave. Doing so might well result in extremely negative consequences for the survivor. This point is often used by the abuser to keep the survivor from turning to these systems for help. Guilt, shame, and pressure. The survivor may have internalized the abuser's messaging that this is all somehow the survivor's fault. They may feel guilt over the thought of breaking up the family, or uprooting the children, or taking the children away from the other parent. Some survivors may even feel guilty about possibly hurting the abuser's career or reputation. Family, friends, and community and cultural institutions, such as faith-based institutions, may exert pressure on the survivor to stay as being the right thing to do for the family or the children. And the survivor may feel great shame that somehow this is their fault, and they cannot leave or it will reflect badly on them, the abusive partner, and their families. Substance use and mental health issues can be barriers. Survivors may have entered into the relationship with these vulnerabilities, and abusers are often quite expert at exploiting them. Or the survivor may develop coping strategies to deal with the impact of the abuse in the relationship, such as using alcohol or drugs. They may develop mental health conditions like depression, anxiety, and PTSD. Abusive partners are usually quick to point out that should the survivor try to leave, their substance use or mental health condition will be a huge negative against them in attempting to access protection from police or courts, or if there is to be a custody action over children, or even when they seek employment and housing. And finally, hope and love. These can be barriers to someone escaping from an abusive partner. On average, it takes a survivor 7 attempts to escape an abusive partner. The first time and the second, maybe the third. One tactic to regain control, which is almost always deployed by the abusive partner, is to express contrition for what has happened and promise it will never happen again and that they will change. Many survivors genuinely love their partner at first, and want to believe these promises. They hope their partner loves them in return and loves the children and see how much damage they're doing to the family. They hope for better things. Abusers are usually very good at manipulation and can seem very sincere. Survivors often care deeply about negative repercussions for the abuser, like jail or loss of jobs, if the abuse becomes public. Once the love finally dies and hope is gone, the abusive partner will switch to other tactics, such as threats, violence, stalking, and running the survivor into court every other month over custody and time-sharing issues in order to try to get the survivor to return or to take revenge for them leaving. So when people ask, why doesn't she just leave? Perhaps the questions we should be asking are, why do abusers engage in these abusive behaviors? And how do our society, our systems, and perhaps even my own response to survivors allow such abuse to be so prevalent in my community? And how can I help support the survivor in front of me, safely escaping the abuse when they decide that the time is right for them to face and hopefully overcome all these barriers? So now you know there are legal definitions for domestic and dating violence and abuse under Kentucky law. However, intimate partner violence is much broader than the legal definitions. IPV is a choice made by a person to use a variety of power and control tactics to exert coercive control over their partner. Although IPV is still very much a gendered form of violence, there is no standard profile of who might be a victim. And although there are many behaviors and traits which abusers tend to share, only some or none of them may be present in an abusive relationship. And finally, it's very important to realize and accept that escaping from an abusive partner is far more difficult than one might think. This is the end of part 1 of the training. In part 2, we'll discuss how physicians can successfully screen for intimate partner violence and how they can respond to disclosures of violence when their patients are making such disclosures. Hello, welcome to part 2 of our training for physicians on intimate partner violence. In part 2, we're going to be talking about screening for intimate partner violence and responding to disclosures. During this section, we'll talk about the physician's legal obligation under KRS 209A, and we'll talk about making good referrals to victim services. At the end of part 2 of this training, you'll be able to utilize at least one intimate partner violence screening question in patient interviews. You'll understand your obligation as a physician under KRS 209A to provide survivors of domestic and dating violence with required information. And you'll be able to make a STAR referral for a survivor of IPV to a victim service program. So why should physicians screen for intimate partner violence? In addition to injuries, intimate partner violence affects patient health in many ways. It can cause chronic health issues related to stress in the cardiovascular, gastrointestinal, endocrine, and immune systems. Intimate partner violence can result in delayed or no access to medical care due to interference by the abuser. It can be a source of depression, anxiety, and PTSD for your patient. Your patient may develop substance use disorder as a coping method. And statistics show that IPV results in poor reproductive health outcomes. STIs, HIV, unintended pregnancy, delayed prenatal care, low birth rate, and of course, the physical violence and injuries suffered during pregnancy. Again, we want to emphasize that screening should be approached through a trauma-informed care lens. What do we mean by trauma-informed care? Organizations and practices that incorporate an understanding of the pervasiveness and impact of trauma, and that are designed to reduce re-traumatization, support healing and resiliency, and attend to the impact on providers while addressing the root causes of abuse and violence. Thoughtful, thorough, regular, and universal screening for IPV is a trauma-informed practice. There are many models of screening for IPV. The one that I'm going to talk to you about today is referred to as CUES, C-U-E-S, where each of the letters stands for a part of the screening protocol. The C stands for confidentiality. I'll divert from my script for a moment just to share that I have experienced being in a hospital setting twice, once with my adult daughter and once with my elderly mother. And I was sitting there in the room, they were the patient, and hospital staff did their screening for violence in the home. I was sitting right there with my daughter, and on the other occasion with my mother, and the questions were asked. And after this, I asked the person that was doing the screening, did you ever consider that perhaps I might be the person abusing my daughter or abusing my mother? They were a little bit embarrassed and made up some reason as to why it was okay for me to be in the room while they asked this question. And it was just a question that was embedded in a series of other questions they were asking. But I use this little anecdote to illustrate the importance of confidentiality when we screen for intimate partner violence. In any form of abuse that's going on in a home, you'll never know off the top of your head whether the person that's accompanied the patient to your office or to the ER might be the person that could be abusing that individual. So when we talk about confidentiality, the screening should take place one-on-one, face-to-face, and with the patient only. Additionally, there are some times when physicians and other healthcare professionals have to violate a patient's confidentiality. This is allowed under HIPAA when a state statute mandates reporting of some form of violence occurring in the home. It's only fair to the patient to inform them of this up front before you start having the conversation with them. Inform your patient of the limits on confidentiality before screening. Be candid with them about mandatory reporting laws. That would include in Kentucky, child abuse and neglect, and vulnerable adult abuse, neglect, and exploitation. For example, you could say, everything we talk about will stay between us, and I'll not do anything without your consent. The only exception to that is if you tell me about child abuse, abuse of a vulnerable adult, or a threat to your own or someone else's life. You get to decide what to share with me, but it's my goal and responsibility to connect you to outside help if you're experiencing one of those issues. This is empowering for the survivor as well. It allows them to decide what they want to share with you at that point in time. The U in the word CUES stands for universal screening. Hopefully, physicians will create the expectation that patients will be asked about intimate partner violence, as well as a lot of other things that physicians need to know about in regards to the health of their patient. For example, you could put a notice on your intake form that all patients will be screened for intimate partner violence. And/or you could put up signs in your waiting room. Additionally, it's important to let the patient and anyone who is accompanying them know that all patients will be seen for a one-on-one portion of their exam. This sets the expectation that this will just be a normal routine part of an office visit or a trip to the hospital. Now, how can you ask the question of, are you experiencing some violence at home? We suggest that you open the conversation by sending a message that you're a safe person to disclose to. That takes the burden off the patient to determine whether, when, and how to disclose. Again, I've signed many forms in physicians' offices that ask something along the lines, are you safe at home? And then another question, do you wish to talk about it? We suggest that the burden should be on the physician to bring the issue up with every patient at some point in time. One way to start the conversation could be by saying, your relationships can affect your health. And I ask all my patients some questions about that. May I ask you some questions related to that topic? In this way, you're setting up the expectation, you're taking the first step, and then you're allowing the patient to decide whether they want to talk to you about this or not. Continuing on with the idea of universal screening, that screening should investigate lifetime victimization. Not only what's going on currently with the patient, but if they've experienced any violence in the past. We now know that traumatic head injuries are fairly pervasive for individuals who've experienced severe intimate partner violence. And that's something that often goes undetected, as well as acts of strangulation, which can also cause cognitive brain dysfunction. And those are really important to screen for. So it may not be something that happened yesterday. It may be something that happened 20 years ago, 10 years ago, a year ago. So make sure that in your screening process, you also talk about any potential victimization that might have occurred in the past. Again, the screening should be conducted one-on-one, face-to-face with the patient, with no partners, friends, relatives, or any children over the age of 2 present. It's particularly important to use professional interpreters if the patient has limited or no English. It's really a terrible practice to utilize a family member, especially a child, to do the interpreting. And if you use the individual's partner, again, they may be doing the interpreting, but they may also be the abuser. So it's really important for you to follow and have appropriate protocols for having interpreters present if your patient has limited or no English proficiency. We suggest that universal screening take place with patients of all genders starting at 14 years of age or at the beginning of adolescence. Why so young? We know that some of the highest rates of intimate partner violence are dating violence incidents, and they're occurring with alarming frequency in individuals in the age range from 16 to 24. At the moment, that's the most highly reported rate of intimate partner violence in this country. So it is important to start young. And even if that individual isn't experiencing any violence, you're setting a good framework for them to understand more about healthy relationships and how they can help keep themselves safe in a relationship. You should make the screening part of the health history or intake for every patient. We recommend that the screening occur after that at least annually. And anytime that it comes to your knowledge that there's been a new relationship or a major change in life circumstance, such as changing jobs, moving, or retirement. It should especially take place regularly during pregnancy. because again, research shows that pregnant women experience higher rates of violence during their pregnancy than when they're not pregnant. Screening is especially recommended in emergency care, urgent care, OBGYN and family planning care, mental health care settings, inpatient settings, and primary care settings. The E in Q stands first for empathy. Empathy is really important when it comes to communicating with a survivor who may be sharing their information with you for the first time. People typically don't want to share this type of very personal, private information with someone that they don't trust. And in order to keep that trusting relationship in place, you need to validate and believe what they're telling you. You can say things like, "Thank you for telling me. I believe you." Very straightforward. Emphasize, this is not your fault. Nothing you did caused this. And tell them, "I'm concerned for your safety and your health." Statements like that will be reassuring to the survivor and reaffirming of the trust that they're placing in you in disclosing what's going on in their life. And of course, reflective language is always important. Reflecting back the language that they use and the emotions that they're experiencing. Things like, "That does sound intimidating. How often does he or she call you those names?" It shows that you're interested, that you're sharing that moment with the survivor, and that you're validating the way that they are feeling and the way they felt when these incidents happened to them. Take what they say seriously and avoid minimizing, even if they minimize. Because counterintuitively, survivors of intimate partner violence often minimize the violence that they're experiencing. It seems to be a mental defense mechanism so that they don't have to grapple with the extremity of what's happening to them. But you can be the sounding point for them, and you can be the voice of reason and not minimize when they tell you that perhaps they've been injured, perhaps they've been harmed or threatened. E also stands for empowerment. So we always want to follow the lead of the survivor. It's really important that as a physician, even though you may be very used to telling your patients, "Well, this is what we're going to do, this is what you need to do, this is what I suggest that you do, this is the course of treatment that we're going to follow," that in this particular instance, it's very important to let the survivor take the lead. Ask them, after they've made a disclosure, "What do you want to do next?" And if you want to be helpful, don't tell them what to do. Ask them, "What do you think would keep you safe? What can I do to be helpful?" And empowerment means giving people options, giving them information, and letting them make the choices that are safe for them to make in that moment. So for example, we'll talk about the brochure that KCADV has available. You can find other brochures easily online or create your own. Would you like to take this brochure with you? It has a number on it that you can call 24/7 to talk with someone who knows a lot about complicated relationships. You can keep brochures available in your bathrooms at your facility, on the counters, perhaps have wallet cards printed up. Why wallet cards? It may not be safe for a survivor to take a brochure home with them. It may not be safe for them to take a wallet card home with them because some abusers are very controlling and will investigate whatever is in the possession of the survivor. So you need to let the survivor take the lead on that. And you don't have to be an expert in intimate partner violence. We're going over a lot of information in these 3 sessions, but ultimately, the most important thing that you can do is offer to connect the survivor with a victim service provider, because they're the experts in this and they can really help the survivor walk that path to safety. You're just the first step. And it's very important that you do these things that will make the survivor trust you, feel validated, feel like you care about them. And that will go quite a long ways towards helping that survivor get to the place where they feel like they can escape from that relationship. Research shows that when good screening for IPV occurs, that women are much more likely to leave an abusive relationship at an earlier point in time. So the S in Q's stands for supported referrals. We call this the STAR model of referrals. STAR stands for supportive, thorough, active, and the quality of the referral. So, to be supportive, affirm your patient's decision, even if you don't agree. We've already talked about the many barriers that survivors face when they're trying to escape from an abusive partner. It may not be the right time for them to leave, but when they know they have somebody on their side and someone who can help them and who believes in them, then that's going to make that decision much easier for them at some point in time in the future. So support them in their decision. It's the best thing that you can do if you want to help them. Be thorough in any referral that you make. Have accurate information about whatever service they need. We're talking mainly today about making a referral to a victim service provider in your area, a domestic violence shelter program. That doesn't mean that the individual has to go into shelter, or they may not want to go into shelter, but our domestic violence programs offer a lot more than just residential services. So knowing about your local shelter, what they have to offer, and how to contact them will make your referral much more thorough. Additionally, if there are other services that the individual needs, knowing how to make those referrals as well, or having people in your office that can make those referrals is going to go a long way towards really helping that survivor get connected. Hopefully your referral will be a very active one. So don't just hand a phone number to somebody. Actively help your patient locate and access the services they need. Assess the patient's need for and help them connect to supportive services, such as a private phone, childcare, or transportation to help them utilize the referral they are seeking. Again, as a physician, you may be thinking, well, this is not my job. I'm too busy. I don't have time to sit there with my patient, go over this information, find out what they need, pick up the phone, and make that phone call. Well, if you don't do it, nobody may do it. You may be the only person that this patient is making this disclosure to. And I would highly encourage you, no matter whether you work in a private practice or at a hospital or some other form of facility, to find out if your organization has a policy and a protocol for this type of situation. When someone makes a disclosure of abuse, it could be child abuse, it could be elderly abuse, it could be abuse of someone with a disability, or it could be someone revealing intimate partner violence. We strongly suggest that you do have protocols in place. And if as a physician, you don't have the time to sit down and have this conversation, then it's imperative that someone on your staff is able, they're equipped, and they're trained to do this and do it well. Finally, the referral quality. If you have the opportunity, follow up with that patient. Ask them about their experience accessing that service and find out if there's anything else that they need. use their experience to better help the next patient who's seeking a referral. And again, I can tell you that my experience has been, as an attorney and as an advocate for survivors of intimate partner violence, it's really disheartening for someone to be handed a sheet of paper with a bunch of telephone numbers on it, and then they come to find out that none of those services are being offered from those places any longer. So that's why this last point is important as well. So if you find out that something that you thought was a community service in your area no longer exists, or they've changed their phone numbers or whatever, you know, that you're keeping that information up to date in your office. Again, why should you do this as a physician? Because intimate partner violence is a national health crisis, and it has severely negative impacts on your patient's health. Patients of all ages, patients of any gender, and as a physician wanting to maintain the good health of your patients, this is really an important thing for you to do. S in the word CUES also stands for safety planning. So as a physician, you may not know too much about safety planning. It's really going to depend on your background. But don't worry, because one of the most important things you could do is connect your patient with a local victim service provider. If the patient is currently at risk, help them plan for harm reduction. How can they seek services confidentially and safely at a local community resource? You need to think about how you can connect your patient to an advocate to do more in-depth planning. And if it's appropriate, you can talk to them about how they might keep themselves and their children safe during a violent incident. We really recommend that if a patient expresses interest in doing some safety planning beyond just some very basic ideas, that you pick up the phone and you get that person connected with one of our programs, which have 24/7 hotlines, and they can speak to an advocate over the phone and do their safety planning over the phone. If the patient states that they're safe now, then you can talk to them about planning for resiliency and prevention. Talk to them about, are they in need or do they want therapy? Are there hobbies or are there exercise, other health issues such as eating healthy? How can they become more socially connected? Managing risky coping mechanisms, and developing future healthy relationships and boundary setting. Again, we don't expect a physician to sit down and be everything to this patient in this point, but if you can connect them with their local community resources, or if someone in your office can do that, you're really going to do a great service to this survivor, and they're going to wind up being a healthier person. The last thing I want to mention is being very cautious about referring someone to couples counseling. And this may be something that they suggest themselves, especially someone who's married. They may want a referral to a therapist to do couples counseling to try to address this violence that's going on in their relationship. The reason we have here that you need to approach this with caution is, as we've said, there's this terrible power dynamic imbalance in a relationship where one partner is abusing the other. And so typically, best practices is that couples counseling should not occur until the violence in the relationship has stopped. And that violence is more than physical violence. It's the whole coercive control that we saw on the power and control wheel. So what might happen if a couple goes to a counselor for couples counseling or marital counseling is that the person that holds all the power in the relationship is going to completely hijack that therapy attempt. And it's usually a very poor outcome for the person who's experiencing the abuse. So at a minimum, the recommendation would be for the individuals to start in counseling with separate therapists and only bringing them together for couples counseling once the violence in the relationship has stopped and stopped for an extended period of time. I also want to talk a little bit about batterers intervention programs. Typically, we refer to those shorthand as BIP. Typically, batterers might be referred to a BIP program by a judge, either through a protective order case or a criminal case. And in Kentucky, they have to attend once a week classes for 28 weeks. It's not counseling, it's a class with other individuals, and the facilitators that are trained to do this work sort of challenge a lot of the beliefs that the batterer is holding onto. So that's a possibility that people can sign up for those classes voluntarily. It doesn't happen very often. But if your patient is talking to you about couples counseling, really you would want to steer them towards a BIP provider. And again, easy solution for you, get them in touch with their local domestic violence shelter program, and then an advocate from that program would be able to help them reach out to a local BIP provider. So when it comes to universal screening and the response that you give to patients, the more you do it, the easier it becomes. Research shows that women support screening and assessments for IPV. Your appropriate response to a disclosure improves both the health and safety of your patient, whereas missed opportunities lead to worse health outcomes for your patients. We recommend that you screen all patients periodically and regularly, starting from age 14. Specifically, during obstetric care, the first prenatal visit, every trimester, and during the postpartum checkup. We encourage physicians and hospitals to set up specific places where there can be a safe space to talk one-on-one with the patient and nobody else present. We encourage the use of printed material and giving that to patients when it's safe for them to take it. And integrating screening for IPV into other routine screening topics. A few sample openings. If you're struggling to think about how you'd want to talk to a patient, you could say, did you know your relationships affect your health? Or you could say, we've started talking to all our patients about what they deserve in their relationships. I have some resources other patients have found helpful. I'd like to go over it with you. Would you like to have a brochure? Or you could say, we've started giving these brochures to all our patients. I want you to know it has numbers to programs that you can call to speak to advocates 24/7, anytime you want to talk about your relationships. And again, beyond you as an individual physician, we're hoping that agencies and medical practices have appropriate responses in place for helping patients who are survivors of IPV to become safe and healthy. So there should be policies and protocols in place that cover screening and how to respond to disclosures. We encourage the creation of safe spaces. Physicians and other staff should know about local resources. All staff should be trained on interpersonal violence and what to do in the case of a disclosure. Universal screening and education should be the norm. And this last bullet is putting some critical thinking and risk reduction around healthcare record entries. So who has access to those healthcare records? Is it the insured? Is the insured the abuser? That's something that you should talk about with your patient before you make any entry into your records. And if you have to make an entry into your records, but the abuser might be able to access that record, think about how you could make the entry in a way that does no harm to your patient. And these two websites provide invaluable materials, resources. I think they'll do technical assistance with physicians to think through these ideas of how can we help our patients who are experiencing violence become safe and more healthy. So I encourage you to check out those resources. Now, I want to talk to you about your legal obligations here in Kentucky in regards to domestic violence and dating violence. These are found in KRS Chapter 209A. So we're going to talk about what physicians need to know about their obligations under the law regarding domestic and dating violence. So what is your legal mandate under that series of statutes? Here's what the statute says. If a professional has reasonable cause to believe that a victim with whom he or she has had a professional interaction has experienced domestic violence and abuse or dating violence and abuse, then that professional shall provide the victim with educational materials related to domestic violence and abuse or dating violence and abuse, including information about how he or she may access regional domestic violence programs or rape crisis centers, and information about how to access protective orders. So breaking that down again is if you have reasonable cause to believe that someone's experiencing domestic violence or dating violence and abuse, then you have to provide that individual with educational material. That's your obligation. So let's look at some of these definitions. What's the definition of professional under this statute? Well, physician is listed as number one, but you can see there's other medical professionals listed here, including nurses. So if you have nurses in your practice or at your hospital, this applies to them as well. And so this list was compiled mostly from a list that was similarly found in the child abuse reporting statutes. That's where most of these were taken from. Physician, osteopathic physician, coroner, medical examiner, medical resident or medical intern. If you're working at a hospital, that's important to know. Chiropractor, nurse, dentist, optometrist, emergency medical technician, paramedic, licensed mental health professionals, therapists, cabinet for health and family service employees, child care personnel, teachers, school personnel, ordained ministers or their denominational equivalent, victims advocates, or organizations or agencies employing any such professional. So hospitals and other organizations that employ physicians and nurses also have this obligation to make sure that this information gets into the hands of victims. How is victim defined in this statute? We're going to go back to the same definition we started with in part one, the legal definition of domestic violence and abuse in Kentucky and dating violence and abuse. So under this statute, a victim is an individual who's been abused by a spouse, a former spouse, or an intimate partner with whom they live or have lived or have a child in common. It also includes an individual who is or has been abused by a dating partner. And a dating relationship, remember, is defined as one of a romantic or intimate nature. So when you have a patient who fits into that category and they make a disclosure of abuse from their partner, that's what triggers the requirements of this statute. Note that it only covers intimate partners, past or present. It does not cover child abuse victims or elder abuse victims. That's because those individuals are covered in two other statutes regarding reporting, mandatory reporting. So under this statute, when we talk about abuse, what are we talking about? In part one, we talked about the legal definition of abuse, and we also talked about the expanded definition of abuse, including everything on the power and control wheel. Well, under this statute, under which you have an obligation, we're going back to the legal definition of abuse. So we're talking about physical injury, serious physical injury, stalking, sexual abuse, strangulation, or assault, or the infliction of fear of imminent physical injury, serious physical injury, sexual abuse, strangulation, or assault. So if your patient is a victim, as we've just defined it, and they're experiencing abuse as we're now defining it right here on this slide, that's what triggers the obligation to give them this information. Now, can you give the information to someone who doesn't fall under these categories? Yes, obviously you can. And we would totally support that. Because even if someone is, say, simply experiencing financial abuse or some form of isolation or emotional abuse, but it doesn't amount to this level of fear that they're going to be injured, it would still be helpful for that person to have the information in the brochure that we're going to talk about, the information that's required by this statute, which is just simply intended to let them know this is what domestic and dating violence is. Here's how you can access help and protection. And so we will talk more in detail in section 3 about these specific terms that come from our criminal code. Okay, so where can you, as the physician, find the information that you're supposed to give to your patient? One option is a brochure that was developed by KCADV, my organization, and it's called Help Is Here. It's a brochure that contains the required brief educational material and information about how to access regional programs and protective orders. It's available in English and Spanish, and it's housed on our website, and there's the link right there. So you can go to our website. On the home page, if you look over to the left, you'll see KRS 209A referral information, and you can click on that link. That will take you to a page that has a lot of information that you can educate yourself with and share with your patients. And there are links to this brochure that you can download and print. As the brochure itself, which is fancy, it has color and it has graphics. That may be something that you want to avoid. You want to just run off a whole bunch of text copies of it. We have that available as well. We have it in large font. And as said, we have it in Spanish. And if you have any questions about that brochure, you can always contact us. My information appears as the last slide of this entire presentation, so at the end of section 3. You're also free to develop or find online your own materials. Just make sure that it covers the 3 bases, which is some information about what is domestic and dating violence and abuse, how people can access their local community domestic violence and rape crisis centers here in Kentucky, and how they can access a protective order. Is there anything else as a physician that I'm obligated to do? So under KRS 209A, that chapter, it also requires that professionals, including physicians and nurses, shall report domestic or dating violence and abuse to law enforcement if and only if, and that's a very important if, the victim requests it and after discussing the reporting with the victim. So what that means is if you're having this conversation with your patient and the patient asks you about reporting to the police and they want your assistance doing that, then under this law, you're obligated to help them. On the other hand, there is no mandated reporting of domestic or dating violence in Kentucky. So that means that if you do that, if you report it to the police or you try to report it to somebody else, like the Cabinet for Health and Family Services, then you will be violating HIPAA because it's not a mandated report. There's another obligation under the law that says professionals, including physicians, shall report to law enforcement their belief that a death of a victim with whom they had a professional interaction is related to domestic and dating violence. And this was put in this statute to sort of circumvent the awkward situation where you've had a patient, that patient disclosed the violence that was in their relationship, then the patient dies. You have some belief that maybe what they disclosed to you is related to their death, but your hands are a little bit tied in regards to, can you release that information without a signed release from the patient, which you can't get because now they're dead, or a signed release from, you know, whoever is going to step in to as administrator of their estate or executor of their estate, or has some authority from a court that they can authorize release of that information. So this allows you to make that report to law enforcement if you have that belief. So just to finish up with KRS 209A, it does say that anyone acting upon reasonable cause in compliance with this chapter shall have immunity from civil or criminal liability. However, knowing or wanton violation of these requirements is a Class B misdemeanor. So the law has a little bit of teeth in it. There's been very few people in Kentucky, even though we've had mandatory reporting laws in place for many years. There's been very few people who've actually been prosecuted. The reason for that potential of prosecution is so that people really know to take a law seriously. We want people to report child abuse. We want people to report vulnerable adult abuse. And in this instance, we want professionals who are having those interactions with victims and getting a disclosure. We want them to provide this educational material to this person so that they can know where to find resources when it's safe and appropriate for them to do so. Remember, when we want to talk about screening and response, we always want to bring that trauma-informed focus to what we're doing. So we want to remember about empowerment, empowering the survivor, collaboration, collaborating with the survivor to choose their own path, the best path forward for them, and giving them choices. And the best way to give them choices is to give them good information. I'm going to go over quickly what we do have in Kentucky in terms of mandatory reporting of child dependency, abuse, and neglect, and abuse, neglect, and exploitation of vulnerable adults. So these are the instances where our statutory mandates allow breaching patient confidentiality, which otherwise would normally be required by HIPAA. And again, there is no longer statutorily mandated reporting of spouse abuse in Kentucky. For those of you who may have been practicing for a while, you may or may not have known about this law that we used to have. We no longer have this law. What we just talked about with KRS 209A replaced the law that we used to have. So your obligations are found in KRS 209A as we've just been discussing. So just a brief summary of child dependency, abuse, and neglect reporting. That's found in KRS 620.030. That statute says any person, so it's a universal mandatory reporting law. Any person having reasonable cause to believe a child is dependent, neglected, or abused shall immediately report orally or in writing to local law enforcement, the Kentucky State Police, the Cabinet for Health and Family Services, the Commonwealth Attorney, or the County Attorney. So you have a choice there. Most people are going to call the CHFS hotline. Physicians may also be required by this same statute to submit an additional written report within 48 hours of additional information that's known if that's requested by the Cabinet for Health and Family Services. So what do we mean when we talk about a dependent child? This is any child other than an abused or neglected child who is under improper care, custody, control, or guardianship that is not due to an intentional act of the parent. So basically, this is a situation where the parent isn't at fault, but they can't take care of their child. So say, for instance, somebody has just moved to Kentucky and they have a very young, a baby or a toddler. They're a single parent. They don't have a support system here in Kentucky, and they're diagnosed with cancer, and they're going to have surgery and go through chemotherapy. And, you know, they may well be able to still take care of their child, but maybe their circumstances are such that they won't be able to take care of their child. So that child may become dependent. And so the state may need to step in and temporarily place that child in another living situation while the parent is going through their medical procedures and care. On the other hand, an abused or neglected child means a child whose health or welfare is harmed or threatened with harm when their parent or guardian or someone who's in a position of authority or exercising custodial control or supervision of the child either does something or fails to do something. So this is more like when the parent or the guardian is at fault. So how could a child be abused or neglected? If the parent inflicts or allows to be inflicted or creates or allows to be created a risk of physical or emotional harm. If the parent engages in a pattern of conduct that renders the parent incapable of caring for the immediate and ongoing needs of the child. Or they continuously or repeatedly fail or refuse to provide essential parental care and protection of the child. If the parent or guardian or a person in a position of special authority, or special trust, which typically means like a teacher, a youth minister, a volunteer, a counselor, if they commit or allow to be committed or create the risk or allow the risk to be created of sexual abuse, exploitation, or prostitution. If the parent abandons or exploits the child, if they don't provide adequate care, supervision, food, clothing, shelter, and education or medical care, any sexual abuse, exploitation, or prostitution where the victim is less than 16 years old and the perpetrator is 21 years or older, or any time someone under the age of 18 is suspected of being trafficked. So in all these instances, that triggers the mandated reporting of child abuse, neglect, and dependency. And as said, those reports are typically going to be made to the Cabinet for Health and Family Services, although you could also make them to the local police, the state police, or a local prosecutor. The other mandated form of abuse that we need to report under the statute, it's just referred to as other adult abuse, but many people call it vulnerable adult abuse. That's found in KRS 209.020. And here, an adult is defined as a person 18 years or older who, because of mental or physical dysfunctioning, is unable to manage his or her own resources, carry out the activities of daily life, or protect themselves from neglect, exploitation, or a hazardous or abusive situation. So what we're talking about here are individuals with a physical or mental disability, but beyond that, they also have to be unable to manage their resources, carry out the activities of daily life, or protect themselves. So this is where elder abuse would fall. Of course, not all elderly people would fall under this definition. Many are perfectly capable of handling everything in their lives, even though they have a disability or two. We're talking about younger people who have a disability that are very vulnerable. And the reason that we aren't including children in this definition is because they fall under the other statute of reporting child abuse, whether they have a disability or not. So what is the obligation? Again, universal mandatory reporting. Any person having reasonable cause to suspect that a vulnerable adult has been abused, neglected, or exploited shall report to the Cabinet for Health and Family Services. Here, the definition of abuse means the infliction of injury, sexual abuse, unreasonable confinement, intimidation, or punishment that results in physical pain or injury, including mental injury. So that's a very broad definition. Exploitation is financial exploitation, obtaining or using another person's resources, including but not limited to funds, assets, property, by deception, intimidation, or similar means with the intent to deprive. So we do see this frequently, unfortunately, with elderly people and also with other people with disabilities who are often very isolated, very dependent maybe on just one person to be their connection to the outside world. And that person is, stealing their bank card or taking their food stamps or something like that. So unfortunately, exploitation occurs a lot with vulnerable adults. And neglect, again, is fairly self-explanatory. A situation in which an adult is unable to perform or obtain for himself or herself the goods or services that are necessary to maintain his or her health or welfare, or the deprivation of services by a caretaker that are necessary. And again, abuse and neglect of individuals who have disabilities, they're at much higher risk for experiencing these forms of violence. And so that's why we have a mandatory reporting law, so that hopefully adult protective services can get in there and help them to find a safer situation. So where do you report for child abuse, neglect and dependency, and vulnerable adult abuse, neglect, and exploitation? There's the CHFS number. And there's also an online portal that professionals can use, and there's the link to that. So that's the end of part 2. And again, I do want to emphasize that just to finish up with the last segment that we talked about, there is no mandatory reporting of spouse abuse in Kentucky anymore, but there is this obligation under KRS 209A that you provide educational materials to victims of domestic violence and abuse, and dating violence and abuse. And we strongly recommend universal, regular, thoughtful, thorough screening of all your patients over the age of 14 for intimate partner violence. We really think that you'll see better outcomes for patients in terms of their health and their safety. Welcome to part 3 of our training for physicians on intimate partner violence. In this section, we're going to talk about legal remedies for survivors of intimate partner violence and community resources. So we'll be talking about civil orders of protection, we'll be talking about domestic violence crimes, and we'll be talking about community resources. At the end of this part, you should be able to name 2 different types of civil orders of protection in Kentucky and who is eligible to apply for them. You should be able to name the most common types of intimate partner violence crimes in Kentucky. And you should know how to find contact information for Kentucky domestic violence programs and what type of services they offer to survivors. So first, let's talk about civil orders of protection. These are civil actions the state is not involved and there's no prosecutor. These orders are initiated when an individual, known as the petitioner, files a petition asking the court to enter an order against another individual, who's known as the respondent. Either or both parties may have their own attorney, although it's a system set up allegedly to allow for both filing and defense without counsel. Many parties are not represented, and there's no right to court-appointed counsel as there would be in a criminal case. There are basically two types of protective orders in Kentucky: the domestic violence orders and the interpersonal protective orders. Who can file for a protective order in Kentucky? First of all, family members. Family members, if you'll remember from our legal definitions of domestic violence and abuse, are defined as a spouse, a former spouse, a parent, a child, a step-parent, a stepchild, a grandparent or grandchild, or any time a child is being abused by a household member. So these are the individuals that could file for a protective order. Additionally, members of an unmarried couple can file for a protective order. Again, these are people who have a child in common, or people who live or have lived together as a couple. Also, persons who are in a dating relationship or were in a dating relationship can file for a protective order. And again, the definition of a dating relationship is fairly simple. It's one of a romantic or intimate nature. Lastly, persons who were sexually assaulted or persons who are or were being stalked can file for a protective order in Kentucky. For these last two categories of individuals, there's no relationship requirement at all. The person who sexually assaulted them or the person who stalked them might be totally unknown to the individual, or it might be a neighbor, a coworker, someone who lives in the same dorm. So they don't have to have any sort of intimate or familial relationship with the respondent in order to file for a protective order. Where would someone go to file for a protective order? In most counties in Kentucky, this is going to be at the circuit clerk's office during normal business hours. After hours, it's going to vary widely. Sometimes it could be with the sheriff. Sometimes it could be at a local police department. In some counties, even our domestic violence programs are where people go for after-hour filing. So the person is going to have to check with their local police department for guidance on that. Now, the petitioner will have the choice to file either in their county of usual residence or the county to which they have fled to escape abuse. And there's no waiting period or formal residency requirement for people who are moving into Kentucky to file for a protective order. They can potentially file for one the day they arrive in Kentucky. How would a person go about filing for a protective order? All filing is done on forms that are provided by the circuit clerk's office or the local after-hour agency. Up to this point in time, there are still many counties in Kentucky that have been utilizing paper forms. The papers are basically provided to the individual who wants to file. They fill them out. Somebody swears them to the affidavit portion, and then those are filed with the court. There are some counties in Kentucky where they have moved to an electronic filing system. In that situation, the person wanting the protective order would have to sit down with somebody who's authorized to enter information into that electronic system. Individuals can also find these forms online. They may sit down and fill the forms out with an attorney or with an advocate. We highly recommend that individuals reach out to their local domestic violence program to find an advocate to help them through this process. The forms aren't that difficult, but it's surely reassuring and helpful to have somebody with some expertise in what goes where and what needs to be written down in order to fill them out. Because remember, this is what the judge is going to be looking at first glance to determine what to do with this case. So it's really important that the right information gets on the form. So the case begins with the petitioner filling out and filing the petition. This is going to be reviewed by a judge. Clerks are not allowed to help anyone fill out the form, but often a police officer or a victim's advocate can help. As I said, it's most beneficial for the survivor to have the help of someone who's familiar with the forms and the process to help. And you can find this help at your local domestic violence program. Now at this point, the other party, the respondent, is not going to be contacted. A judge is simply going to review the petition and decide if the case should move forward. The individual who's filing the petition is going to be sworn to the affidavit part of it where they state what happened. And so it's like giving testimony in court. If the judge reviews the form and feels that the case should move forward, then the judge is going to instruct the clerk to set the case for a hearing, and they may issue an emergency or temporary order to be in place until the hearing. I'd like to talk a little bit about what the judge is going to be looking for when the person files that petition. And we've talked about the legal definition of domestic violence and abuse and dating violence and abuse. So when the person fills the form out, they're going to have to put enough information about the incident or the history to show that domestic or dating violence and abuse, as it's defined legally, has happened. That's going to trigger the judge setting the case for a hearing. And then if what's in the petition also indicates to the judge that there's an immediate danger of more violence occurring, they'll probably also issue that temporary order. So what happens once the case is set for hearing? The clerk is going to send a copy of the petition and a summons to local law enforcement, who will attempt to serve it on the other party, who again is called the respondent. If the judge feels like there's that presence of danger, then they are probably also going to issue either an emergency protective order, which we refer to as an EPO, or a temporary interpersonal protective order, which is referred to as a TIPO. What's the difference between those? It's simply based on the relationship between the parties. The emergency protective order, which we've had in Kentucky for many, many, many years, is for domestic violence and abuse. So that's violence occurring between family members or members of an unmarried couple. The interpersonal protective order and its emergency form, the temporary order, is a newer creature. We've had those for about 3 or 4 years in Kentucky now. This is for people who are experiencing dating violence and abuse, or people who've been sexually assaulted or stalked by someone that they have no relationship to, or not a familial or intimate partner relationship with. So that's the real difference between an EPO and a temporary IPO. So if one of those is entered, that will also have to be served on the respondent. And typically what that order will say is it tells the respondents to stay away from the petitioner until the hearing. One point to note, it's important that law enforcement be able to find the respondent in order to be able to serve them with these orders. The petitioner should be ready to share information about where the respondent can be located when they file the petition. So if you as a physician are discussing protective orders with a patient, make sure that they have that information handy when they go to file. Why do people file for a protective order? The main reason that people want a protective order is for the no contact portion of it. This tells the respondent not to have any direct or indirect contact with the petitioner. Also, if the two share a residence, the order may tell the respondent they have to move out until the case is heard in court. If the respondent violates any portion of the order, they could be arrested and charged with a Class A misdemeanor violation of a protective order. The other piece of an emergency order that can be important is that the judge can give temporary custody of children to the petitioner. Children can also be included on the order such that the respondent cannot have contact with them until the hearing. It varies across the Commonwealth. There are judges in Kentucky who don't want to issue or enter orders regarding the children in any way, shape, or form. So your local domestic violence program would be able to give your patient some guidance on that, and whether it's likely that the local judge would give them some form of temporary emergency custody via the protective order. So the petition gets filed, the respondent gets served, and now people are going to appear in court. And by statute, the first court hearing should be set within 14 days of the granting of the petition. So what's going to happen at this hearing? The hearing is like most court hearings. The parties and any witnesses are placed under oath, and they're going to give testimony. Sometimes evidence will be introduced, like a medical record or a police report. So you may have a patient reaching out to you to get a copy of that medical record for this court proceeding. There may be attorneys representing one or both parties. The judge is the trier of fact, there's no jury, and the judge determines if a long-term order is warranted. The judge is going to be listening and looking for evidence that proves it's more likely than not that the respondent committed an act of domestic or dating violence or stalking or sexual assault, and that violence may happen again. So that's why those definitions that we've gone over are important. If the judge so finds, then they'll enter a long-term domestic violence order or interpersonal protective order. Again, it's merely a matter of what they're called. They basically do the same thing. The domestic violence order is available to people who are experiencing domestic violence and abuse, that is, family members or members of an unmarried couple. The interpersonal protective order is for people who are experiencing dating violence and abuse or sexual assault or stalking. Both of these long-term orders can last up to 3 years. It's up to the judge to determine how long they last. And as it's getting towards the end of whatever the term is, the petitioner can go back into court and ask that it be extended. So what happens after the hearing? If the judge enters that long-term order, then the respondent has to abide by whatever is in the order or risk being arrested for a violation. Most petitioners are wanting the order to instruct the respondent to stay away from them. At the hearing, the judge might, and that's a big might, consider matters of temporary child custody and visitation, use of a marital residence, short-term payment of mortgages, utilities, and health insurance. But typically, judges do not want the hearing to turn into a mini divorce or separation agreement. They would refer the case on to instruct the parties that if they want all those matters hammered out, that either one of them can file for a divorce or file for a separation or file for original custody action. These hearings tend to be pretty short in duration. And so oftentimes the judge does not want to get into all these collateral issues and mainly wants to focus on just, was there violence and do I need to enter this long-term order? As a part of the long-term order, either or both parties might be ordered to counseling, specifically to address the violence in the relationship. And again, I'll use that term BIP, which stands for Batterers Intervention Program. So sometimes the respondent will be ordered to attend BIP classes. Those meet once a week and they last for 28 weeks. They're facilitated by a trained BIP provider who's a mental health care professional. Unfortunately, we don't have BIP providers in all parts of the state. I think we now have about 200 or so of them scattered around the state. So in some counties, the judge can't order the respondent to go to BIP because there is no one available. That order, in addition to the emergency order that might have been entered earlier, is entered into LINK, which is our Kentucky statewide law enforcement computer system. And that's really good because it makes it easily accessible to all law enforcement across the state 24/7. So that was a very brief overview of the civil protective orders. Again, that's a civil action brought by an individual against another individual. So we're going to shift gears and talk a little bit about criminal domestic violence law in Kentucky. So as opposed to a civil protective order case, in a criminal case, the state prosecutes an individual for violating one of our state penal code laws. The federal prosecutors can also prosecute for violation of a federal criminal law, and there are a few directly related to domestic violence, but that's really very rare. So typically this is going to be in state court, and such a case is initiated either by the police taking a report after a domestic violence incident has happened and then filing it with the county attorney who then acts on it. Or sometimes the survivor will go directly to the county attorney and file a criminal complaint. Of course, sometimes a person is arrested initially right after an incident occurs, or once a judge has issued a warrant. Other times, the person will just receive what's called a criminal summons to appear in court. If the person has been arrested, they're entitled to have bail set, and they may be eligible for non-bail pretrial release. For cases involving violent or sex crimes, a judge is supposed to make sure there are adequate conditions on their release to keep the alleged victim safe. Typically, this takes the form of an instruction that the criminal defendant have no contact with the alleged victim. This operates as a sort of criminal protective order for the survivor. So let's talk about some common domestic violence crimes in Kentucky. Kentucky does not have a specific crime of domestic violence assault. A person who assaults a family member or other member of an unmarried couple or a current or former dating partner will be charged with regular misdemeanor assault, usually. Assault in the 4th degree is what it's called here in Kentucky. It's a Class A misdemeanor, and it carries a possible penalty of up to 12 months in jail and a $500 fine. The definition of assault 4th involves intentionally or wantonly causing a physical injury to another person. And the definition of physical injury is a low standard. If you'll recall, in both sections 1 and section 2, I said that we would be talking about these definitions in section 3. So here we are. So when we talk about domestic violence and abuse, dating violence and abuse, and we think about that list of how those can be committed, if there's physical injury, serious physical injury, stalking, strangulation, sexual abuse, sexual assault, and assault. So now we're going to talk about how those are defined. So physical injury is a very low standard to meet in Kentucky law. It's simply defined as substantial physical pain or impairment of any physical condition. So if somebody hits another individual in the face and leaves a bruise or a mark, Typically, that's going to be enough to qualify as a physical injury. Of course, we have felony assaults in Kentucky. Assault in the fourth degree is a misdemeanor, and then we go to assault in the third degree, and that's our Class D felony, the lowest level of felony in Kentucky. It carries 1 to 5 years potentially in prison. Assault in the third degree in Kentucky is reserved for assaulting a police officer, a jailer, a probation and parole officer, and individuals of that nature. So it's a felony because of the nature of the person that you are assaulting. So in order to get to a felony assault in the domestic violence and dating violence realm, we actually have to bump up to assault in the second degree. And that's a Class C felony. It carries 5 to 10 years potentially. And the definitions here, the elements of this crime are much harder to prove up. So it involves a serious physical injury. So for assault second to stick, there has to be a weapon involved and a physical injury, or there has to be a serious physical injury without a weapon. And a serious physical injury under Kentucky law is defined as one which creates a substantial risk of death or causes serious and prolonged disfigurement, impairment of health, or loss or impairment of a bodily organ. This applies if the victim of the assault is 12 or older. So there's a special category under assault second for very young victims, children who are less than 12 years of age. And so the standard of injury doesn't have to be as high in order for an assault second charge to lie when the victim is very young. But so for those 12 and older, there has to be this serious physical injury. And so when you look at this definition, a substantial risk of death, serious or prolonged disfigurement, impairment of health, or loss or impairment of a bodily organ. When you think about injuries like a broken bone or someone who has been beaten fairly badly and has lots of bruises, or some, cuts, lacerations, etc., oftentimes that cannot be charged as an assault second because those injuries, even though they may be severe in a common sense form of the word, under our law, they don't meet this definition of creating a substantial risk of death or causing serious or prolonged disfigurement or impairment of health or loss or impairment of a bodily organ. So that's sort of a gap we have in our Kentucky law. So that's why the most common level of assault charged in intimate partner violence situations in Kentucky is going to be misdemeanor assault, assault in the fourth degree. And if a prosecutor chooses to go forward with like an assault second or an assault first charge, they're definitely going to need a physician to come in and testify that this injury that the victim sustained meets this definition of serious physical injury. We do have the ability under Kentucky law to enhance the misdemeanor assault fourth to a Class D felony if it's the third offense in 5 years, if it's domestic or dating violence related. So there is that. It's not used very often by prosecutors, but there is that possibility under our law. So again, by far, most domestic violence and dating violence assault cases are going to be charged as assault fourth. So some other common intimate partner violence related crimes. Criminal trespass. We have varying degrees of this under Kentucky law, first, second, and third degree. But basically, this is when you're going on to someone else's property without their permission. And this happens frequently, especially when the survivor of the violence is trying to separate from the abuser. And then the abuser doesn't want to acknowledge that boundary that the survivor is trying to set. And so wherever the survivor is, they're coming over to their house, or maybe it's a relative's house, etc. And they're not leaving when they're asked to leave. So that could be criminal trespass. Criminal damage of property, again, this is fairly common, either during an incident where things are being torn up, or during a separation or right after a separation where the abuser destroys whatever property was left behind by the survivor. That's fairly common. Terroristic threatening, that would be anytime somebody makes a serious threat of death or serious physical injury. And so, that can be kind of contextual. It is a misdemeanor crime. It's frequently seen in intimate partner violence cases. And nowadays, it's most frequently seen through texts, sometimes social media posts, but where the abusive partner is making some very specific, serious threats of harm to the survivor. Harassing communications is just simply, having communication with that survivor with no legitimate purpose. So we've probably all heard stories of where, somebody received 150 texts over the course of one day from an ex-boyfriend, an ex-girlfriend, an ex-spouse, or, someone you've just separated from. So that would be a harassing communication. It could occur online as well, social media, chat, text, phone calls. Wanton endangerment is when you do something that is, puts somebody else or other people's lives at risk. Even if you're not intentionally meaning to harm somebody, your actions are just so wanton that it rises, to a crime. So say, for instance, you're in a room full of people and somebody pulls out a gun and joyously shoots a hole in the ceiling because they're happy and that's their way of expressing joy. You would probably feel very endangered. Maybe you wouldn't, but maybe many people would. And could they possibly have hurt somebody by doing that? Probably. So their behavior might rise to the level of, oh, it was very wanton and they endangered other people's lives. In intimate partner violence cases, where we see this is often enough when the two individuals are in vehicles, especially if there's been a separation. And so you have the survivor of the violence in a vehicle, you have the abusive partner in a vehicle. They see the survivor out in town or in the county or whatever, and they're going to chase after them. They're going to try to make them pull over or try to run them off the road, actually. And oftentimes there's children in one or the other vehicle. And so you may see someone being charged with wanton endangerment for doing something like that. And again, brandishing weapons, that can be also a crime. It's a misdemeanor crime, but if it gets a little bit more intense, it could rise to the level of wanton endangerment. Unlawful imprisonment, this also happens a lot with IPV cases, where basically the abusive partner says to the survivor experiencing the violence, you can't leave. You can't leave the bedroom, you can't leave the house. And then they take action, in order to make sure that person doesn't leave. They lock them in the bedroom or what have you. So that's common. It's not commonly charged by the police, but it does happen quite a bit. And then, of course, unfortunately, we get all the way up to a homicide. And it's interesting that there's been at least one study that shows that the biggest predictor of whether or not either party in a heterosexual relationship will die at the hands of the other party is if the female in that heterosexual relationship is being abused by the male. So what that says is that, yes, what we commonly think of is the male will at some point kill the female, right? The male is the abuser, the female is the person being abused. But what also happens, unfortunately, is sometimes the female in self-defense whether it's classic self-defense or something more removed from an immediate dangerous situation, but the female will kill the male abuser because they see that as their only way of protecting their own life. So homicide is the ultimate price that people pay for intimate partner violence. There are other crimes, of course, rape, sodomy, and sexual abuse. So there is an awful lot of sexual violence that occurs in intimate partner violence cases. It is a lethality indicator. So where there is sexual violence going on, and as it gets more violent, that is an indicator that the survivor's risk is going through the roof. And so, you know, do people rape their partners? Yes, they do. Do people sodomize their partners? Yes, they do. And do they commit sexual abuse? Yes. So I'll just talk really briefly, sort of like what is the difference between these crimes. Rape is basically penetration of the sex organs, and it used to be with a foreign object or the sexual organ of the other party, the perpetrator, but they've changed that recently to include penetration by any body part. So, and that can be committed either through forcible compulsion, which is the use of force, or threat. Okay, so force, I think we all understand what that is, you know, if you force someone to have sex with you with physical force, but it can also be accomplished through a threat, and the threat could be explicit. I have a gun in my hand, and if you don't let me have sex with you, I'm going to shoot you. Or it can be implicit. So like one case I dealt with where the individual was wanting to have sex with his partner, and she was like, no, I don't want to have sex. So he took a fish fillet knife out of the nightstand and laid it on the pillow next to her head. So that was an implicit threat that if she didn't let him have sex with her, that he was going to use that knife on her. So that would be potentially, you know, you could charge that as a rape. Another way to commit rape and then these other crimes, sodomy and sexual abuse, is also when the survivor does not have the legal capacity to give consent. So I think we all sort of think about this as statutory rape, and it's dependent upon somebody's age, right? So young people by law cannot consent to having sex. And the laws here in Kentucky are getting more and more complicated in regards to who can and cannot give consent. And so we have these cutoffs of children under the age of 12, and then children who are 12 or 13, and then children who are 14 or 15. So in those various categories, there may be this blanket prohibition, this person cannot give consent to having sex, or it may depend on the age of the other partner, if that makes sense. So for children under the age of 12, they absolutely cannot consent to having sex ever. For children under the age, for children who are 12 or 13, if the other party is 18 or older, then the younger party cannot consent to a sexual act with that older party. If the child is 14 or 15 and the older party is 21 or older, then again, the younger party cannot give consent. So we now have a new law that says, very new, I think it's been around for 1 year, that if the child is 16 or 17 and the other party is 10 years older than the child, then that 16 or 17-year-old cannot give consent. I need to take a sip of water. So Maybe we need to take a little break here. All right, I apologize for that. I had to take a little break because of my voice. We were talking about these sexual offenses, rape, sodomy, and sexual abuse. I was talking about the age differentials and a new law that applies to rape and sodomy, that if there's more than a 10-year difference between the age of a 16 or a 17-year-old partner to the sex act and the older partner to the sex act, that now is also going to be chargeable as rape or sodomy. So as I said, our laws just keep getting a little bit more nuanced and complex. There's other ways that people can not be able to have the legal capacity to consent to a sexual act beyond just their age. And that would be obviously someone who has doesn't have the physical ability to refuse. So if you think of a situation where someone slips somebody a drug and then that person is passed out, or maybe the person has just been drinking and they've passed out, and then somebody else, has sex with them regardless, that could be charged as rape. And the other instances are typically where the party is in some sort of a custodial setting. So if someone is an inmate in a jail or a prison, or if it's a younger person who is in foster care, then even if they appear to be agreeing to have sex with the other person, they really don't have the legal capacity to give consent. And so that other person could be charged with one of these sex crimes. Recently, there's also been a change in the law in regards to people who have an intellectual disability or a developmental disability, where it used to be sort of a blanket, someone who has an intellectual disability can't consent to having sex. But that takes away a lot of the autonomy of someone who may have that type of disability. And on a case-by-case basis, it may actually be possible for them to understand what they're consenting to and, to really agree that this is what they want. And that's a very complicated and nuanced type of situation. And it's really going to be up to the local prosecutor to decide whether the other person in that situation would be charged with a crime or not. So that's why I say these laws are getting very complicated and hard for the common person on the street really to understand, which is unfortunate. But so we talked a little bit about what is rape as far as physically, it's penetration of the sex organs. Sodomy, on the other hand, is when there is contact between either the mouth or anus and the sex organs, and sexual abuse is more of touching, really of any body part for the sexual gratification of either party. So either the sexual gratification of the victim or of the perpetrator, or both. So those types of crimes do occur within the context of intimate partner violence. And as I said, when we talked about interpersonal protective orders, even if you don't know the other party, you're the petitioner, you can file for a protective order if you have experienced sexual assault. And the definition of sexual assault is either rape or sodomy or sexual abuse. So that's the basis for getting a protective order, as well as they are, of course, standalone crimes that could be prosecuted. Stalking is the same. It's the basis for getting a protective order. It's also a crime. We have misdemeanor and felony stalking. Most people, sort of a layperson's understanding of stalking is, well, someone's following me around, they're hiding in my bushes. But the legal definition of stalking is it has to be a course of conduct, so 2 or more instances. It serves no legitimate purpose. It targets a specific person or persons, and then it has to place a reasonable person in fear that they're going to be harmed or sexually assaulted. There has to be a threat, either explicit or implicit. And so sometimes, a case of, literally someone just following another person around, it wouldn't really rise to the level of criminal stalking, nor would it possibly be basis for getting a protective order. So there has to be a threat of physical injury or sexual assault. And it has to place a reasonable person in fear and give them extreme mental distress. So does stalking occur in the intimate partner violence realm? Yes, it does, both before and after a separation. So it can be used as a means of surveillance by the abuser against the other partner, checking up on them, looking at their phone, following them, showing up at work. And then after the separation, incidence and rates of stalking goes up because then, for someone who's really an abuser and they're into this coercive control, they hate losing control over their partner. And so by stalking the partner, they're trying to reestablish control over them. And so that's something that we do see charged occasionally. They're really complicated cases to get all the evidence together and, to successfully prosecute them. And then the last bullet point, strangulation. This is a new law, was just added to our penal code last year. And the reason for it being its own sort of standalone charge, as opposed to blending it in with like regular assault, is that the act of strangulation, again, is a real risk indicator in intimate partner violence. It means that that perpetrator, that abuser, is getting to be a very dangerous person. So under our law, an act of strangulation is where you cut off another person's breathing or blood circulation, either by applying pressure to their throat or neck, or by placing something over their nose or mouth. So it actually sort of also encompasses smothering. And I know from having spoken with people who are experts on strangulation and prosecutors, it's really, really important to have good medical evidence, if at all possible. I know one of the sort of standout signs of strangulation is if the hyoid bone has been fractured. So for anyone who practices emergency medicine, I would hope that if someone comes in and they're reporting that they've been strangled, that an x-ray would be taken. I think that would hopefully show that fracture. Or even if after the fact, someone has reported that, there was an act of strangulation somewhat recently, that they could be sent for x-rays, to preserve that evidence. What really needs to happen is police and EMSs really need to be trained on looking for that, so that when they are responding to a situation, again, so that they should screen for strangulation, and if somebody discloses strangulation, that they should try to do the best job they can to collect evidence, even if it's just the testimony of the individual. Of course, strangulation to the point that someone has blacked out or they lose loss of their bowels or bladder, I mean, that person is getting very close to death. So strangulation, if it's charged, it's always going to be a felony. It's going to be either a Class D felony, if it is wanton in nature, and it's class C felony if it's intentional in nature. So as physicians, hopefully you will, have some training on that. We wanted to get some funding in the bill that passed to provide training to physicians, police officers, and EMTs. That didn't happen. But if you ever want any more information, feel free to reach out to me. Again, my contact information is at the end of this presentation, and I can probably put you in touch with individuals who have a lot of expertise in this realm. But definitely, we would highly suggest screening for strangulation if somebody is disclosing that they are a victim of, physical violence as, intimate partner violence. All right, so we're going to switch gears here and talk just a little bit about community resources. And I've mentioned throughout the presentation how important it is to make a good referral and help your patients find resources to help them with the violence that they're experiencing in their relationship, or really if they have any questions about their relationships, their intimate relationships. And so I'm only going to list our website here. I'll tell you a little bit about our organization, the Kentucky Coalition Against Domestic Violence. We're a nonprofit entity, but we're also considered a quasi-agency of the state. And that is because by statute, the Cabinet for Health and Family Services has to provide domestic violence services to survivors in all 120 counties of Kentucky. And what they do is they contract with KCADV to provide those services. And we in turn subcontract with our 15 member programs. So we have 15 state and federally funded domestic violence shelter programs across Kentucky. There's one in each area development district. And if you go to our website, you can find the one that serves your area. And so all of our 15 programs provide legal and court advocacy, case management, safety planning, support groups, and one-on-one advocate counseling. Some of our programs actually have licensed therapists, and we do a lot of housing assistance. So people can't stay in a shelter forever, and we can get them federal housing vouchers so that they can go out and find safe and affordable housing, and we can actually help them pay their rent as well. So there's a lot of services that our programs can provide. So really, as a physician, what you need to know is how to find that local program in your area, and then how to make that good STAR referral for a patient when they disclose that they are experiencing violence, if they want to get more information. And the brochure that I've talked about, Help is Here, it has this information in that brochure as well. But that's the only website that you need to know, because from that website, you can find a whole lot of other resources out there. And if your patient needs help with getting food stamps or getting KTAP or getting Medicaid or other public benefits, or they want to find a local food bank or something like that, I don't feel like it's your job as a physician to do that for them. But if you can connect them with our local program, then the advocates at that program will help them do that. So that's the link that you can provide. And of course, we do offer shelter. People don't have to come into shelter in order to access our services. But shelter is available to survivors of intimate partner violence and their dependents. We shelter people of all genders, and whether they have a disability or not, we're going to make accommodations for them as appropriate so that they can be safe. So I hope that you will remember write down our website there right now, stick it on your desk somewhere and have it handy along with our brochures. I was asked to speak a little bit about the intersection of our COVID-19 pandemic and intimate partner violence in Kentucky. So our shelters have remained open, which was very tricky because, it's congregate community living. Typically in a shelter, if a family comes in, they will get a bedroom to themselves. But single survivors, when they come into shelter, are usually going to be asked to, double up with another person. So we've had to move away from that, trying somehow to maintain social distancing. Bathrooms in shelters are often communal as well. So what we did in March was many of our programs moved to sheltering people in hotels. Some of our programs are still doing that. Others have done a deep cleaning of the shelter and come up with policies and protocols, so that people can go back into shelter and try to be healthy, both the staff and the residents. So, everybody being masked and closing down, communal kitchens. We've had to, in some shelters, reduce occupancy so that each person coming into shelter can have their own bedroom. We have been very, very, very lucky, and I'm knocking on wood here as I speak, that we have only had one confirmed case of COVID-19, and that was early on in April. And we were lucky that that program happened to have some transitional housing apartment units, so we were able to move that person and her children into an apartment right away so that they could quarantine. We have had to restrict people's movements more than we would like. We try to keep the traffic in and out of the shelters way down. And as I said, some programs are still sheltering people in hotels, especially people who need to work, so that they can go in and out and get to their jobs and back and forth without, coming into shelter multiple times a day. The demand for shelter also went down, and I think some of that was because we were upfront with people and said, if you come into shelter, we're not going to be able to let you just come and go as you like. And, they made the choice that that wasn't for them. Some programs were able to, like I said, put people up in hotels, so they had a little bit more liberty. Our hotline calls went down initially. We feel like that is a result of when people were staying at home with their abusers, it was really difficult for them to find a safe place and a safe way, to make that hotline call and reach out, not necessarily to come into shelter or get services, just to talk to an advocate about what was going on. Our programs did report that even though the number of calls were down, that the intensity of the calls seemed higher. People were reporting, much like more dangerous situations, and the calls were lengthier, like people were wanting to stay on the line for an hour or more. So we'll see if those numbers go back up now that Kentucky is, reopening in stages. We're seeing a little bit of a difference between our urban centers and our rural parts of the state. The rural parts of the state, our numbers are still down. And I think that people just struggle so much more in rural areas with issues like transportation, employment, maybe because of job loss. The abuser is home more, or the survivor doesn't get to go into work and there's no safe place to call from. And maybe they've had their phone turned off because they can't pay their phone bill. So it's going to be interesting and possibly heartbreaking to see what happens with survivors as we march through this slow process of trying to get back to some sense of normalcy. The courts remained open. for people who are wanting protective orders. They are open right now. There are measures in place, to try to keep people safe and healthy. And many courts moved having hearings online. So through Zoom or Skype. That's been very tricky for survivors. It's been tricky for everybody. But I think the courts were trying to do the best they could to still make sure that people were able to obtain protective orders. The intimate partner violence homicide numbers in Kentucky appear at this point to have remained about the same. I think since about March, we've had about 10 homicides, and maybe last year during this time, I think the number might have been 9. So we haven't seen an uptick in that yet. I don't know that we will. One thing that we have been trying to work very hard with the Department of Public Health is on contact tracing, because if somebody who is in shelter does test positive and a contact tracer wants to contact everybody they've been in contact with, we have issues with violating people's confidentiality and trying to keep people safe. So we are working with the Department of Public Health to sort of iron out that process so that shelter residents and staff can be tested, that contact tracing can occur if it's necessary, and that people can be healthy. But at the same time, we want to make sure that our survivors stay safe. So, so we're almost at the end of the presentation. Just to recap some of the highlights that I really hope that you have taken to heart after this training is, how do I help an intimate partner violence survivor? First and foremost, be supportive. Don't be judgmental. You may be the only person they're making this disclosure to, and the way that you react to them is going to be critical to how they perceive whether it's safe or not going forward to tell people about what's happening in their home. I hope that you now know how you can provide resources and how you can empower the survivor with knowledge so that they can use that when it's safe and appropriate for them to do so. Even as a provider, a physician, be ready to help if the survivor decides to leave. Again, you don't know, what piece of that puzzle you may be playing for that individual. And also be prepared for it to not always work out the first time or the second time or the third time. We've discussed all the barriers that survivors need to surmount in order to really reach a safe place. And so the most important thing that anyone can do for a survivor is to continue to be supportive. As physicians, please keep documentation safely so that you can provide it in the future if necessary to confirm that the survivor self-identified as a survivor of violence, but make sure that it's in a way that it won't inadvertently get into the hands, of the abuser, and then there could be, some retaliation on their part against the survivor. And always remember that intimate partner violence is a choice being made by the abusive partner who wishes to exert control over their partner. The behavior of the survivor is not the cause of the abuse. And you should let your patient know that and, support them and keep sending that message to them and providing help in a way and in a shape that they're asking for and that's safe for them. So I think we have reached the end of the presentation. Here is my name, Meg Savage. I'm legal counsel for the Kentucky Coalition Against Domestic Violence. Please feel free to reach out to me at any time. There's our phone number and my email. At this point in time, as we're all teleworking, it's probably easiest for people to reach out to me by email. If you call our number, that's our office phone number, we do have people answering the phones and they'll get a message to me. So I hope that you found this presentation helpful. If you have any questions, please submit them to KMA, to Miranda Mosley, and she'll get them to me and we'll get them answered for you as quickly as we can. Thank you.